This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Stacey Clardy from the Salt Lake City VA and the University of Utah. We are back with the second in a two-part series, talking with Walter Koroshetz, Director of NINDS, on all things neurology and neuroscience research, an especially relevant time to do this interview as NINDS is celebrating its 75th anniversary, right? On today's episode, we'll get more into some of the ongoing challenges and successes with a lot of useful information. Walter, thank you for being here today.
It's a pleasure, Stacey.
I have so many questions. The Brain Initiative's budget, for example, has changed with the Cures Act taper. It went from $402 million in fiscal year 2024, which was a drop from 2023, further tapering in 2025 to $321 million. We see funding go up and down. Let's talk about that vulnerable young investigator. This is the first major dip they're seeing. They maybe got an optimistic score on their grant, and it wasn't enough to make the funding cut in lean times. What do you say to that investigator?
You can't really sugarcoat things. The NIH system is a competitive system, and the vast majority of grants that we get they don't get funded. But I would say if investigators continue to write grants, the data is that eventually they do get funded. So it's really a matter of persistence and staying in the game. The great thing about application system is you can send in an application, you get your critiques back, and then you can resubmit and take those critiques seriously. Don't argue them, agree with them, and then fix things going forward. I would say for the early stage investigators, NIH has, at least over the last couple of years, and particularly NINDS for a long time, has made special efforts to fund early stage investigators. An early stage investigator, which is 10 years from their last training, gets double the regular pay line. For K awards, which is the signature career development award for neurologists, we don't have a pay line. We pay any grant that gets a good score, which usually means anything in the 10s, 20s, or low 30s. So one of our priorities here at NINDS is, no matter what, we want to protect the workforce so that when you have a dip, you don't lose a generation of investigators, because then that's not coming back. So that's one of our highest priorities, is to try and bend over backwards to give people a chance as they enter this area.
That's helpful. Are there any underused mechanisms you would highlight? Interdisciplinary or public-private partnerships?
The usual mechanisms, that R01, then there's the training grants. The one that turns out to be underutilized is loan repayment. The loan repayment can actually be quite generous. I forget, they increased it, was like $60,000 a year potential repayment of federal loans. And that one, we do notice that we don't get as many applications as we should. I think the other applications, mechanisms, K awardees, which, as I mentioned, and for neurologists is the Career Development Award, signature one. The number of applications hasn't really changed since 1990. It's about 70 applications a year, the KOAs, K23s put together, and that hasn't changed. And the truth of the matter is one of the big bottlenecks for getting therapies out to people is the lack of trained clinical investigators. So we're really attuned to that, and would like to see more people put their career into research on the clinical neurology side. Yeah.
Couldn't agree more. Along those lines, let's talk about doing the science. I noticed that appropriately, rigor and reproducibility have remained central, and I saw that NINDS recently spotlighted the Rigor Champions Prize and related efforts. What are the most practical steps neurologists can take this week, even if they're not leading research, to strengthen design, blinding, reporting? Talk to us about that aspect of what you do.
Yeah, you want to develop a skeptical, scientific thinking mind. And so my mentors would approach things in peeling back the story that's around the research and just focusing on what were the methods, what was the data, what was the analysis plan. And when you do that, you can see not just the beauty in science, but the actual, what they call now at NIH, the gold standard of way to do things. Not only as you design things, but even when you read papers, to tune your mind into being real skeptical about and very critical in how you read papers. One simplistic and certainly not totally true way of thinking of things is when you read a paper, the data and the methods are the real key things, and everything else is an advertisement. People trying to build a story around their data. It's not that it's bad, but to realize that's what it is. And the real gold is in the data and the analyses and the methods. And if you start thinking that way, when you're reading papers, which you can do it today or tomorrow, then that'll basically carry over when you design your experiments or look at your data. Rigor is really important. Science is all based on what's true, and a lot of things that were thought to be true turn out not to be true. That's part of science. But you'd like to be on the true side as you move forward in your work. You have a reputation for your science that's really important, and the people who have the highest recommendation or the highest regard as scientists are generally not just the ones who publish in fancy journals, but the people who make discoveries that are true and open up new areas. And that's all based on the rigor in which they approach their work.
Agree. I want to ask your opinion on something. There are so many diseases in neurology that we're seeing in our clinics that don't yet have an approved treatment. What do you think should be our approach to those conversations? And I guess in there, it's a little bit of self-examination over the prior years too, but I think this comes up for all of us. We get in the habit of borrowing treatments, of using things empirically, our judgment, right? The clinical judgment that we try to hone. What is our obligation, and how do we approach as a whole this conflict of, I've done it this way for years, the patients seem okay, and now all of a sudden there is a clinical trial. There's a tension there. What is your take on how we approach this? If there's clinical trials available, should I be going on clinicaltrials.gov with every patient for which there's no treatment really quickly in clinic to make sure? What would you say, in your opinion, we should be doing in clinic for the myriad of neurologic patients that fall in that category of no approved treatment?
I could tell you that people talk to me, say disease organizations, and they'll say, why isn't there a trial available for all patients with my disease? And they point to pediatric brain tumors, where they say pretty much everybody with a pediatric brain tumor is in some kind of clinical research. Mm-hmm. So I think, as neurologists, the data is such that neurologists have not been really great about informing people about clinical research. I remember studies done in Parkinson's where there's a number of disease-modifying trials that were ongoing, and they interviewed patients, and overwhelmingly the neurologists never mentioned them to the patients.
Oof.
That doesn't sound right. So you want to inform the patient. It's up to the patient what they want to do, that's for sure. But it is something, an obligation we have when we're dealing with diseases that don't have known proven treatments, to inform people about clinical trials. And that being said, there's this other wing which might say if there's no approved medication, then don't give them anything. I wouldn't ascribe to that. I think you always want to do the best thing by the patient in front of you. You have to be a little careful that you're not being motivated by a chance occurrence in the last patient you treated and assuming it generalizes to all your patients with that condition. So you have to be rigorous even when you do that as well. Now, my mentor, C. Miller Fisher, would argue that you can actually learn a lot from an individual patient and trying different things, but being rigorous about it and making discoveries. So as a neurologist, you have that opportunity. The patient is always reporting out what's going on in their brain and nervous system. If there's reason to try something, making a really good observation sometimes is what leads to a new therapy. I know for essential tremor, people found that heart patients with essential tremor, when they got beta blockers, their tremor went away. And
right.
So that was clinical observation.
I'm taking a lot from what you said there. You said a lot. Anecdotes, not data, But for an individual, if there certainly is no option, if there is no ongoing trial, you do have to partner and you do have to come up with a reasonable strategy that makes sense based on that N of one patient. And if there is a trial, let them know. Knowledge is power. That's informed decision making. Every time you give an answer, it pops a new question into my mind. And so then I'm thinking about, okay, things are moving along quickly and you can't look around without seeing artificial intelligence everywhere. So you're probably getting bombarded with people just trying to sneak AI into research proposals. What do you see as a rational approach, a way to leverage AI technology? What's a good way to look at this from a proposal point of view, even from in the clinic point of view? What's your take on the rapid changes in AI?
It's a new world there. There's no question it's not going away. And there's no question there are dangers in its use or misuse. And I think that people are going to figure out how best to use it for health in the next 10 to 20 years. There's going to be a lot of advances there. The key thing, again, is to be rigorous about it. And there's a really interesting paper, I can't remember exactly where it is now, but it's on biases that can affect the outputs of AI. And it's actually in a radiology journal. The reason I know is because I'm involved in an NIH program to use AI to bring neuroimaging into research with other medical data. So the example there is just think of all the hospitals in the country and the millions of images that they collect, and they do reports, which, are out there in their medical records, but the images are real biological data, and it's not possible because of the enormous numbers of them to do any research except through AI. So we're really interested in that project and using AI to interrogate images, whether they're chest x-rays or MRI scans, pathology slides in large numbers to integrate with the clinical data to make predictions. It's real biological data that's just been sitting dormant in terms of research in the hospitals all around the country. In terms of things like, say, the Brain Initiative, for instance, I mentioned before that right now we are collecting data on millions of neurons simultaneously in awake behaving animals. And you can't look at it and say, I know what this correlates with, because it's just not possible. So these machine learning techniques are the only things that can allow you to do that. And one good example is a study that came out, I think it was in New England Journal. There was an ALS patient who has a recording device in the motor strip for oropharyngeal muscles. And that data is then streamed, or the firing of neurons is streamed out and put through a neural network and a large language model so that data can then create that person's words through a computer in real time. Now, we've been working on that with different groups over the years, and it's been very slow. Words will come out, but they're far and few between. They're not quick enough to be useful. They are useful, I must say. They are. People who can't communicate at all now can communicate. But until the large language model came out, where you can predict the next phoneme from the first one and the word from the phoneme and the next word from the previous word, the speed just went off the roof once you could use those kind of technology. Clearly, we've seen areas where without AI, you can't make progress. So that's the low-hanging fruit. How far AI can go to see patterns in a patient's history that would help a doc make the diagnosis, that's for the future.
So lots of opportunities. I want to give you a last word here, more of an open-ended question. I've appreciated all your insights, your candor, right? We're in a bit of a funding dip right now. We're in challenging times with maybe societal trust of science and things like that. Any other insights or thoughts for clinicians and researchers around the world on things we can do today and generally where your thoughts are and how to continue to move things forward, make a positive impact?
There was a recent survey done by Research America about who they trust the most. And I think it was maybe school teachers were at the top, and then doctors, nurses, and then scientists were third, and politicians were at the bottom. So don't forget. But I think it's true that we're not in the position that we would like to be in. There's a lot we can do. When we talk to people, we have to take every opportunity we can to explain what we do as scientists. For instance, the person in the shopping mall, in the Uber, in mowing the lawn next to you, because we spend a lot of time talking to people who are just like us, and we think, oh yeah, it all makes a lot of sense. I don't know why everybody doesn't believe it, but we don't spend a lot of time talking to people who are not scientists or not in medicine about what we do. And so it's really not that surprising that they have misperceptions about how things work or what we do. And the other thing, the people who are at universities, there are a lot of the universities in parts of the country where this is critically important to do. And people have respect for their state universities or the schools in their town. The government is not going to be able to fix this problem. The government is,
Right.
It's going to have to be grassroots, because that's the way it should be. It should be grassroots. People should hear some real stories and make their minds up. But I think we have to be more deliberate about it and recognize that we really do need to take the opportunity of working through our patients. Certainly, research is basically the effort to try and make things better for patients. That's what research is. And certainly in neurology, that's what it's all about, whether it's understanding something basic about the nervous system or developing a new treatment. Our whole purpose is to try and make things better for patients. And research is the process by which we do that. And so it's an inherently valuable activity. And I think that people will appreciate it if they understand what it's all about.
Yeah, that's helpful. That's practical. I can certainly do that today. I want to thank you, Walter, for your leadership and the honest and earnest guidance today. We've covered a lot, and I appreciate your creativity, your leadership, your strategies, and ideas. Thanks so much for your time.
Stacey, it's been a pleasure.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes, or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.